Thanks so much for the podium. I have no relevant disclosures. So, lessons learned. We could probably end the presentation here and say we hadn't learned so much. In this land of free vaccines, so plentiful that we're actually throwing them out after they expire, we're sort of watching history repeat itself. But I'll keep talking in the spirit of being me. So a couple of lessons. Number one is to pay attention and to be proactive. The pandemic was evolving for months before it hit New York City and the US. The first cases occurred in China back in December. And then we saw firsthand as the virus ravaged and shut down Asia and Europe, particularly in Italy from our colleagues. There was a World Health Organization global health emergency issued by the end of January after the first US case, and then the US soon followed suit. By the start of March, it was a worldwide pandemic, and we caught up 2 days later, with our surgical world rapidly changing after that time. It's 4 months of lead time. This is literally what it looked like. So there was fair warning. The virus became really real for us in New York City back in March. February 22nd, there was a 50-year-old man, worked in New York City, lived in a suburb of New York, who went to a bat mitzvah with several hundred people. This is the benefit of contact tracing. This gentleman didn't feel well that week. He went to a doctor's office 4 times as an outpatient. And finally, on February 27th, he was admitted to one of the Columbia affiliate hospitals. They didn't know what he had. He was there for several days in several different units until they thought maybe it was COVID. He was then transferred to Columbia's main hospital, going through the ER again, several other units, and admitted there. It wasn't until March 3rd that he was diagnosed with COVID. By that point, there were 22 known contacts of him that were COVID positive and 1,000 others that had to be quarantined, and they actually quarantined a 1-mile area around his house. So that was the start of it. At the same time, it wasn't until March 4th that we had the first institutional email that COVID was a risk at the institution. At that point, no masks, no real protections. It wasn't until the 10th of March that we were told to wear masks when patient-facing, and until the 14th where the first death happened. Things rapidly evolved after that. On the 16th, elective surgery was stopped, but that was at the same time that there was a statewide mandate to stop elective surgery. After that, ORs were rapidly converted into ICUs, common areas, the lobby, all converted. The ICUs were holding 3 times the capacity. There was cross-contamination because testing wasn't done as well or as widespread as it probably could have been, and rapid redeployment with elective surgery stopped, and surgeons in every other group sent to cover ERs, cover ICUs, cover inpatient floors, because staff was also getting sick. There was no national guidance, no citywide guidance, no designated centers, and really no equitable allocation of resources. And each hospital was left to devise its own strategy based on its resources in the COVID population. This was an awful thing to see. This is the views coming and going from the hospital. The triage areas spilled out into the streets, and the dead overpowered the morgue's capacity. Freezer trucks were brought to the hospitals to help. Inside was even worse because there was this awful quiet in the ICUs and in the ERs as people were intubated, and really just a chorus of beeps and muffled sounds while we tried to talk to each other. The city mobilized to create extra beds everywhere, sports arenas, the Javits Center, which is the big convention center there, Central Park, and even bringing in the US Comfort ship. And the city that never sleeps was silent, empty, and really scared. There's views that are usually packed with people in tourist areas, the Bowl at the end of Wall Street, Grand Central, the Oculus, the Exchange, empty. So lesson number 2 is the importance of a comprehensive leadership plan. This is basically what we were getting. Daily responses on the lack of preparation. The initial response was late, and it was just to delay all surgeries. There was so much we didn't know, fear to spread the virus while we were operating. The OR was really only essential personnel, so there was no resident education or fellow education. Patients were afraid to come to the hospital, so they were deferring their visits entirely or presenting with really awful pathology. And initially, poor quality research helped fuel the fear. There were also disparities and dilemmas with surgeons for the first time ever having these moral issues. Non-operative management for things they'd normally operate on, rationing of ventilators and care, selecting patients for who's sickest or are they going to die and shouldn't have attention, reusing PPE that we knew shouldn't really be reused, families being separated, both healthcare providers because they were afraid to infect their families, and patients having to go to the hospital alone with no visitors, and many dying alone. It's really an awful scene that happened. And disparities in the access to care were highlighted during this time also. Marquee institutions with endowments had much more money, staff, services, and equipment, even in the same health service system, leading to better outcomes and better survival. So there was some help over time with COVID surge, overtaking the evidence-less publications and coming out on how to prepare, how to organize teams with elective and emergency work safely. They provided evidence from countries that had already gone through it and developed domains to help organize a response for surgical services. So lesson number 3, poor preparation has long-lasting effects. Sorry, I know I'm going long here. I'm gonna breeze through this. My actual patients. We're also learning from the initial poor preparation, lack of organized response. Cancer patients initially were not presenting for care. Cancer referrals dropped dramatically. In the month of April 2020 alone, urgent referrals were down 60%, the number compliant with treatment down to almost 20%, ER visits down nearly 60%, and elective cases down 85%. A modeling study from England converted these delays into additional cancer-related deaths and loss of life years. And this data is from England, but it's pretty generalizable across most developed countries. And it shows that for this 3-month period between April, May, and June, there's a dramatic number of lives lost with 25%, 50%, and 75% backlogs. And at that time, they thought it was just gonna be an additional 3 of 8 months. Deaths and life years lost, at that point, were gonna grow exponentially. We're way past that. And the additional delays to treatment of another 2 to 6 months led to a substantial portion of patients with early stage cancer progressing from curable to incurable disease. Here in the United States, 22 million cancer screening tests were disrupted just during April and June. And this is the highest for colonoscopy. And the estimated reduction in the number of tests ranged from 30 to 72%. It's scary. And from this, we can see that it wasn't just screening tests, office visits, biopsies, all therapies were impacted. It's something to keep in mind because we continue to have this issue. And the number of canceled cases is a worldwide impact, but highest in low and middle income countries. So how do we manage this? Lesson number 4 was to learn to trust big data. After terrible publications in high-impact journals, the COVID Surge Collaborative emerged, and it might be the shining light that came from COVID. They used generalizable large-scale audits to demonstrate the impact on elective case cancellations, cancer case cancellations, time and money needed to clear waiting lists, the risk of M&M from operating on COVID-positive patients, when to operate, and when to resume elective surgery. They also provided pathways to help safely organize and restart elective cases. So, very good guidance. Lesson 5, sorry, I know I'm over, but this is a good one, is that SAGES is always going to be there for you. Like we heard from Jonathan, just so much admiration for my colleagues, as we created a rapid response team that immediately investigated from sources, dispelled myths based on available data, adjusted statements as new data became available. If you heard a rumor, in less than 24 hours, SAGES would address it, and all information was available for free online. They also tackled this paradigm shift in education head-on, with a diverse array of the webinars, surgical education and leadership, as well as notes from the Battlefield series. And one last quick thing that we learned is that it's okay not to be okay, because truly none of us are. Burnout's highly prevalent and it's increasing. Well before the pandemic, up to 69% of general surgery residents reported burnout. and 44% each considered dropping out of training and said if given an opportunity, they wouldn't enroll again. And the issue isn't unique to trainees. This is a 10-year-old study from the EAES that showed that 40% of us at that time were considered burned out and emotionally exhausted at 32%. This is even before we talked about burnout. And last March, we had the additional weight of COVID and these strange feelings that we don't normally talk about from COVID put on our shoulders as additional weight. Everyone's sad, everyone's emotional. In a survey of the impact of how US physicians are coping, almost 2/3 said the pandemic has intensified their sense of burnout. Physicians have reported feelings we don't usually talk about. We're exhausted, overwhelmed, scared about the lack of PPE and spreading the virus to loved ones. We're afraid of getting sick, and almost all of us were sick at one point and scared about not getting better after being sick. And nearly 23% reporting suicidal ideation with no effective coping mechanisms. So this impact can't really be quantified. And I just want to end by saying to just please be kind to each other and to yourselves. So thank you.